I'm going to set this up for primarily practicing the various kind of cases we believe it will show up on the boards. So I don't have any disclosures, and we won't be talking about any off-label indications or usages during this discussion. What we hope to achieve by the end of the next hour and a half or so is that you'll have some practice with coding. And for the last couple of years, we've really tried to replicate the type of coding sheets that you'll see on the boards so that when you get to the boards, it won't seem so foreign, because there's a lot of different options that you can code. You'll be able to see a number of examples of cases that we think will be likely, and I'll try to give you some practical hints about coding. The echo for the boards basically says that they'll test everyday echo. And we don't think there'll be very many M modes, but I will show you some because knowing the type of people that write boards, they've been around for a while, so they want you to know some of the classic M modes. And most of us aren't practicing or even being taught M mode as much anymore. So maybe over the next few years we'll see that change, and I'd love feedback on M modes. But I still have a few very classic ones in here for your review. We'll also talk, of course, about the transthoracic echocardiogram, and you should be very familiar with the major windows that you get: the parasternal views, the apical views, the subcostal views, and the suprasternal views. And of course, there would not be outside the realm of testing to show you transesophageal, so we've got some of those included: Doppler calculations and different measurements that you might be responsible for as you go through the boards. I do have one disclaimer, though, and that is and I guess we, because in putting this talk together, Dr. Sunil Mankad started this talk a number of years ago when we first started having that coding section. And we've, of course, updated and added cases over the years, but Dr. Mankad and myself and Dr. Martha Grogan, who's a heart failure, amyloid, and adult congenital heart disease expert, and also with some help from our other colleagues in the Echo Lab, went through and coded all of the answers as we thought that they should be coded. But it's really our suggested answers. We really don't exactly know how they scored the imaging section. But what I did do is do probably the same thing you did, and if you haven't done it already, I recommend that you think about doing it, is go to the ABIM website. They do have a bit of information there about what coding they expect. So they want you to interpret cases as you would in everyday practice. To me, that's reassuring because most of us read a lot of echoes in our everyday practice. And then the examination is really not to be considered an exercise in identifying minutia or clinically unimportant details. And that's left up to our judgment. And there again, when the several of us that went through and did do these codings to present to you all, we would debate a little bit about what is clinically the most significant. And I think that almost every single case will have a money shot, if you will. The one thing that they really want you to make sure that you got, and if you get that, you're probably going to get the major amount of points on that particular case, just like with the ECGs. But they will expect you to pick up some other things with each of the cases as well. And so therefore, try to think about what other things you might include. But don't try to read more into the case than's actually presented. And I'll try to make those points as we go along. And your score then is really going to depend upon those main diagnoses, not selecting things that are wrong, things that would hurt the patient or lead to the wrong management plan for a given situation. And also, you want to make sure you don't accidentally select mutually exclusive options, and that you are not selecting significantly more options than is judged to be correct. And again, that's left up to your judgment, our judgment, and something that we're not going to be divulged. And they will, I guess the problem is if you can click every single thing, you might get some of the right ones and some of the wrong ones, so they'll be taking points away for clicking too many. This is what the answer key looks like as it is presented on the ABIM. Now, last year when we put this together and we decided to go to the portal, the ABIM had tabular tabs, just like you'll see in your portal. And this year, when I went to the ABIM website, they had given you this big, long answer sheet that has multiple different options on it. And I've given you the website here in case you want to take a look at it yourself. I can't tell you for sure whether they're going to use the tabular format that we have now in the portal for you to practice with, or whether they'll present you with a whole sheet. But what I can tell you is that the tabs are organized by the major areas on the answer sheet. And I would really try to familiarize yourself with what's under each of these, the left ventricular size, function, and structure. And you can code your, whether there's LV enlargement or it's normal, infarct, or LV infarct complications, wall thicknesses and masses, then LV diastolic function, all under, the function category, and the ejection fraction, and then any wall motion abnormalities, whether there's an abnormal wall motion and then, or global. And then if you say there's abnormal wall motion and it's not global, you're expected to put into the coding system what areas you think are either hypokinetic, akinetic, whether there's thinning or scarring or an aneurysm, pseudoaneurysm, etc. And then similarly in valvular heart disease, you can see there's a lot to remember kind of where it is. It's coded, it's organized in a way that I think will make intuitive sense, but not always. And then right ventricular size, function, and structure, types of cardiomyopathies and systemic diseases. And really the only two systemic diseases that they have are amyloid and hypereosinophilia. And then pulmonary diseases, diseases of the aorta, diseases of the atria, pericardial and pleural diseases, and congenital heart disease. So the format that I will follow over the next several minutes to an hour and a half or so is to present you a case and then allow you about 25 seconds. Now, the actual coding section, they say, has 37 cases on the boards, okay? So the image section will have 37 cases, and that's going to be distributed between echo, cath, and any other images that they decide to pull. So that gives you about 3.5 roughly minutes per case. Today, because we wouldn't want to stay here for 3.5 minutes and I want to get through as many cases as possible, we're giving you 25 seconds. And after we've been doing this now for a number of years, that seems to be about where the audience is most comfortable. I've polled the audience year after year and they say that that's about the right. I mean, there's a little bit of a bell-shaped curve. There's always people that like more time and people that like less time, but I think 25 seconds. And that way you kind of get the gist and we can make a couple teaching points on each of the cases as we go through. So without further ado, I think I'll go ahead and start going through our cases. So case number 1 is an M mode, and they're going to give you a little history similar to this. So this is a 32-year-old female who presents with palpitations. And this is an M mode, and you can see the little thumbnail sketch up at the top of your screen here that shows you where they're taking that M mode through. And then they're going to possibly present you with the M mode below. So take a look at that. And then there's our answer key. And again, in yours, I think it works better because it's tabulated, so you can actually work to each of the tabs that you think might apply. And then now we'll start the clock, and we'll give you 25 seconds to think about what you want to code on this particular M mode. Okay, so time is up. Now I'm going to show you what we coded, and this is an M mode short axis view of the left ventricle. That was a little thumbnail at the top, gave you that orientation. And under the valve tab, we would have coded mitral valve prolapse. And then if you had taken the time to look at the size of the ventricle by counting the number of centimeters, you would have realized that the ventricle was within normal limits, so you could code that. It's a smaller font, meaning that we think that this is probably minor, and that the major thing would be the mitral valve prolapse, and that wall thickness was normal based on that M mode. And actually, M mode still is a very good way because it gives us that ice pick view of the ventricle to measure things like wall thickness. And we still do use it in our lab, but I know many places around the country don't even teach it to their fellows anymore. So I'll take a couple minutes to remind us all what we're seeing. So when we stick that ice pick down on the anterior short axis view, we're going to first come to the right ventricle. We see the right ventricular wall up here just underneath the EKG. Then we'll come to the ventricular septum. Then we come to the left ventricle, and in the middle we see the mitral valve, and then the posterior wall and a little bit of the pericardium is that bright white line in the back. And if you look at your EKG to time, you have systole when you have ventricular contraction, and then diastole when the ventricle obviously is relaxing, the mitral valve opens, so you have early opening, which is the E bump. And then you have mid-diastole where the mitral valve, and you all know this looking at 2D images too, that the mitral valve tends to float, especially during a slower heart rate, closed a little bit during diastasis. Then we have the atrial contraction, the mitral valve opens up again, and then closure at end diastole. Just before, and then the D just at the end of diastole once the mitral valve opens, before the mitral valve opens again. So the mitral valve prolapse will show you, looks like this. It has multiple different echoes that we see prolapsing posterior motion of the mitral valve back towards the posterior part of the M-mode trace. So that was the classic mitral valve prolapse M-mode. Now I'll give you another classic mitral valve M-mode, and this is your little thumbnail sketch on top. And we'll just let you take a look at that because it will pop back up in your portal when you key in your answer now. And again, you get a few seconds here to answer this. And this was with case 2. Again, we have an M-mode short axis of a patient with hypertrophic cardiomyopathy. Under the valve section, you would code that the mitral valve demonstrated systolic anterior motion, and this would be hypertrophic cardiomyopathy, and that wall thickness was increased in an asymmetric way. And again, this is smaller font. Again, I think the major parts that, of points that you would gain on this one is our judgment that that would be the systolic anterior motion, which is really the classic part, and you should note that the wall thickness is increased. And these are centimeter markers here, so you can actually see how very deep the wall thickness is as you go through. I don't even think you really need to use calipers. Now, we don't have calipers built into our portal that I'm aware of, but I think in the boards they will have calipers, but most of the time you can get the gestalt looking at the centimeter markers on the side of your echocardiograms. So here again is this EKG down here. So you have onset of systole, the mitral valve is closed, but it's moving, unlike our mitral valve prolapse, which is a posterior motion, this is actually moving anterior in the ventricle, and you can see it's being pulled towards the septum, are fondly referred to as SAM, or systolic anterior motion of the mitral valve apparatus. Now, case 3 is a transesophageal echocardiogram, and this is a 50-year-old male who had dyspnea and chest pain and ended up being diagnosed with coronary artery disease, and this is the intraoperative transesophageal echocardiogram just prior to his bypass grafting. I don't know how well you can see that. It's 4.55 meters per second. Go ahead and key in your answer now to what you think is going on with this transesophageal echocardiogram. And I'll display the image again. I know you can see it on your portal as well. All right, so the coding on this one for case number 3, the 50-year-old gentleman with dyspnea and chest pain, pre-CABG transesophageal echocardiogram, has asymmetric septal hypertrophy, and you might then imply from that that he also has hypertrophic cardiomyopathy, valvular heart disease. He again showed that systolic anterior motion that we previously saw in the M mode, but now this is with transesophageal, and there was either mild to moderate mitral regurgitation. LV function was normal to hyperdynamic, and then you could code potentially left atrial enlargement. Again, I don't think that's going to, it may be a neutral coding, it may give you one small amount of points, and then there was an RV catheter or pacemaker wire in this patient that was being monitored, of course, at the time of his intraoperative transesophageal echocardiogram. And several times when I've shown this before, people miss that catheter that's there. Again, I don't think that's a major miss. The main thing that you don't want to miss is you want to alert your surgeon that this patient has hypertrophic cardiomyopathy. There's a dynamic outflow tract obstruction that's causing SAM. You can see the proximal flow convergence of the accelerated flow through the left ventricular outflow tract. You can see this posteriorly directed jet of mitral regurgitation. And with CW, we're picking up a very high velocity in the LVOT. So those are the key points there. And I think we're moving right along here. We've got 25 cases total that I put together for this, and we'll go on to case number 4. This is another M mode example. Again, I just picked a few of the most classic M modes. 53-year-old female with dyspnea. And here is your little thumbnail. So we're going from the surface, that little ice pick view of the heart. And I'll let you decide what we're going through based on your expertise as echo coders. You can go ahead now and key your answers in, and we'll try to give you a little time to do that. But here's our answers that we decided to code on this M mode through the mitral valve. You saw you showed the ice pick coming down through the right ventricle, through the ventricular septum, and then through the left ventricle, really highlighting this process of mitral stenosis. So if you remember the original M mode that I showed you, the normal M mode, we're taking this ice pick, and it's coming from the surface through the right ventricular free wall, through the ventricular septum, and then down through the mitral valve right here. And here you can see the septum and the mitral valve, and this is the mitral valve during systole. When it's closed, you can time it with your QRS complex, and then it should open, and we should have an E, F, and A wave. But in this situation, we have these very thickened leaflets that don't open well, so they aren't separating like we saw them separate in the normal M mode. And also there's a very flat EF surface area, if you will, or line that you can draw. So we don't actually have that demarcated EFA that looks like a little bumpity bump on our normal M mode. So I think if you know those very classic M modes, the only other one that I don't have in this one that's not used to be on the front of all the Feigenbaum textbooks is a myxoma for M modes. But you might look that up if you haven't seen an M mode of a myxoma. So here's a 65-year-old male with chest pain. And I'll let you take a look at the left panel here, and then a zoom view of this panel. And we'll show you some more images. Make sure when you take the boards that you do go through all the pages of images. It's easy to sometimes forget that there might be more. You usually have to click on multiple different images to get them to come up. And here we have another view from our transesophageal echo with the same patient, 65-year-old gentleman with chest pain, and then with our color Doppler added in there for assessment of the valve. And there's a still frame with some cursors, which are a little hard to see. They're measuring a distance here, 5.2 in the ascending part of this picture. You won't have anyone to narrate for you on your boards, I might add. Go ahead and key in your answers, and then we'll go over those images. So this is our 65-year-old gentleman with chest pain, and he has an aortic dissection. So you go to the diseases of the aortic tab, and you'd pick aortic enlargement, which was the narration that I was trying to kind of clue you into. But in addition to having an aortic enlargement or aneurysm, you'd also obviously code the fact that there was a big dissection flap. I think the dissection flap is going to be very important, and that's probably where the major points will come from, but I don't think that they would want you to overlook the fact that this patient had an ascending aortic aneurysm. And there was some valvular dysfunction, there was aortic regurgitation, and what we talked about when the team of us that coded these decided that we would pick mild to moderate unless there was some other way to really quantify, unless there was overwhelming evidence that it's severe, okay? So there'll be some more examples that we'll come across when you would code severe, but I think in this situation, unless there's overwhelming evidence that there was severe aortic regurgitation, I would code mild to moderate, and then only code severe when you really have that evidence. And we'll see some examples of that as we go on in our cases. So the other thing was there was a catheter or a pacemaker wire in the right ventricle in this particular case too. And I'm not so certain how much that little part would be important, but you can see it right there in the still frame. In the left panel here, you can see what's known as the long axis view with the left atrium up here, the mitral valve here, the left ventricle down here. We see the aortic valve, and we see this very serpiginous linear echo density flopping back and forth within the ascending aorta, which is right here. And again, in a still frame view, you can measure, as they were doing on that still frame view, that the ascending aorta was over 5 centimeters. And if you could take out your calipers, but even if you just count, 1, 2, 3, 4, 5, and then kind of, wow, it shouldn't be more than 4 for sure. And so there is an aneurysm there. So that's how you would know. Now, here's what we should really be using in the lab. We should use the guidelines that were published by our chamber quantification, and we really, when we sit in the lab and we have the luxury of time, we're going to divide our patients by their age and body surface area to determine the range of normal for an ascending aorta. And there's tables like this in this very nice document by Lang in co-authors that was published in the Journal of the American Society of Echo. But I think in our, when we're taking boards, we need to have some key numbers that we remember so we know when we have an aorta that's enlarged. And Roman and Devereux published the first criteria based on this, and we measure the aorta in several different spots in the ascending aorta. So if this is the LVOT, this is the LVOT diameter. Here's the sinus of Valsalva. Here's a sinotubular junction, the ascending aorta, and many labs will even try to measure another measurement higher. And those measurements are the ones that we should kind of keep in mind to code this aortic enlargement or aneurysm. In patients over the age of 40, which is the vast majority of our adult patients, for the ABIM, we're primarily going to be tested on our adult patients, the sinuses of Valsalva should not be larger than 4.5 centimeters, and the ascending aorta should not be larger than 3.8. If you see, though, certainly not larger than 4, and my guess is that they're going to really make it obvious to you so that you can use either the caliper tool on your echo, or you can just use the markers that are on the side of the centimeter markers that show up along the side of the imaging sector. So those are some numbers I would commit to memory. And then in practice, I would go back to the documents and have those readily available in your lab to refer back to in terms of aortic enlargement. Now, in terms of how to code the dissection, for the boards, they've actually decided to use the Stanford classification. So we have a picture of our aorta here. If the tear originates in the ascending aorta, then it's going to be a type A, whether it goes the entire length of the aorta or whether it's isolated to the ascending aorta. If the tear begins in the descending thoracic aorta beyond the left subclavian artery, then that would be considered a type B. And so you don't have to worry about differentiating between the other types of coding. It's just Stanford A or B. Ascending for A or B for the descending aorta. All right, case 6. We have a 70-year-old man with dyspnea, and we're going to be asked to code why this patient has dyspnea. And I'll let you take a look at these pictures. There's a couple more for your viewing pleasure here. So now this is the long axis view, and I'll just point out that this happens to be the Mayo format. So our right ventricle is on the right side of the screen. And with the color on it, it's a little hard to tell, but the tricuspid valve is always most apically displaced. So if you're ever in question about which ventricle is which or which format something's in, the tricuspid valve always travels with the right ventricle, and it's always the most apically displaced. So you can tell that the right ventricle here is on the right side of your screen. And now, this is what I think that they'll ask you to do, is to be able to tell cutoffs for valvular heart disease. So we give you some measurements here. In case you can't see exactly where they were putting those cursors, I took and highlighted them with bright green, my favorite color. And then you saw the distance, a little zoom view in that long axis view of the valve in question. Again, the left ventricle is on the left side of the heart, left side of the screen on this Mayo format. And we'll have you go ahead and key in your answers. All right then, so what did we code on this one? 7-year-old man with dyspnea. I think we know why he's got dyspnea now. It's valvular heart disease and severe mitral regurgitation. So now we have quantitative evidence that he has severe mitral regurgitation due to mitral valve prolapse, but I also think it would be very important to have seen the flail chordae that were flapping back into the left atrium. I'll point that out. There was a calcified mitral annulus, which is probably important. And we did debate a little bit about how important that is, but the surgeons really like to know that because, of course, when they sew in this, when they repair the valve, it becomes an issue about how difficult it could be to repair. And then aortic valve regurgitation, mild to moderate. We didn't have any quantifiable information on that. Left ventricular ejection fraction, normal to hyperdynamic. Left atrial enlargement. Again, I think those last two and the aortic regurgitation are more on the minor side, but certainly something that could be tested. But I think the major points are going to be garnered in making sure that you know this was mitral valve regurgitation due to a flail, ruptured cord, and mitral valve prolapse. So these are the key images. So we see the calcium here in the mitral valve annulus, this really bright echo-dense spot. We see the prolapse of the mitral valve posterior leaflet beyond the annulus, and it's more than 2 millimeters beyond the annulus, which is a key. And then you also see in this view, which is the aorta here, and we have, it's a long axis view, you can see the chordal structure that we could see in the left atrium, and then torrential mitral regurgitation during systole. So I think it's quite important to note that, and in real time, if you pay attention right up here, you can see that little wiggly thing, which I think maybe on your screens that you have really close to you, sometimes these cords can be difficult to pick out, but they'll want us as echocardiographers to be able to see that. And then, of course, there is very torrential, colorful, that wraps around the whole left atrium, but they also gave us measurements where we could think about Pisa. Now, I think it's going to be difficult in 3.5 minutes to pull out your calculator and necessarily calculate Pisa all the time. So I want to give you a couple shortcuts that I think will be helpful to you when if they give you some quantitative measures. So you can take the radius that's measured, that proximal flow that comes towards the hole during systole, right here. Here's the mitral valve, and we see this proximal flow convergence that we fondly refer to as the Pisa. And then that's the R squared. So you can take that distance, which was 1.2, and square it and divide it by 2. If you take that by divided by 2 is 0.6, the R squared. However, and if it's greater than 0.6 centimeters, that's going to be severe. So if you have an aliasing velocity and you set your aliasing velocity, which is really a good rule of thumb, start at an aliasing velocity over here where you've moved the baseline towards the regurgitation. This baseline was not moved, but we usually move it in the direction of the mitral regurgitation. If you do that, then it's set at about 30. If your mitral valve regurgitant velocity is at least 5 meters per second, and your Pisa's radius is over 1 centimeter, you can be sure that it's severe. So here's a very close-up view again of the mitral valve, showing that those little cords that are ruptured, and that makes the diagnosis that I think probably is the major diagnosis: mitral valve prolapse and mitral regurgitation, severe, and a flail or ruptured chordae tendineae. And for the boards, they call that a flail. All right, that was a big case, and of course that would take maybe all of your 4 minutes to figure it out in the actual test. Case number 7, we have a 73-year-old gentleman with a murmur. I'm going to give you some more information here. In the actual exam, you'd be tabulating, clicking your next image arrow to see the next images, but I'll be happy to do it for you in this setting. And we have several different views here, short axis and long axis zoom view. And you can see a measurement just below the aortic valve there, highlighted in green, so you can actually see it. And then our Doppler information. Now, one thing that I'm not 100% sure, that they'll probably have to give you the traces, but they'll probably also make you determine which is PW and which is continuous wave Doppler. For those, most of you who are in the Echo Lab would recognize this right away as a pulse wave Doppler, because it primarily measures the modal velocity at the point where the cursor is. So you're getting all the red blood cells moving just in that sector. Whereas the continuous wave Doppler fills in the entire spectrum and gets every single velocity of red blood cell moving in the same direction as your cursor. And these two views will really help you to determine what numbers you want to use in your formula. For our purposes here today, and also because it's hard to see what's actually on the screen, of course I've given the LVOT, PW, TVI, the aortic valve continuous wave Doppler is 118, and then the mean gradient of 59 millimeters of mercury with a peak velocity of 4.7 meters per second. So go ahead and tabulate your answers on this case. I'll give you back the key information. All right. So with that one, we had a lot of things to think about. 70-year-old man with dyspnea and a murmur, I think we all could see that he had significant calcific aortic stenosis. So you'd go into your valve tab and you would code calcified aortic valve with severe aortic stenosis. The left ventricular size seemed to be normal, and there was increase in wall thickness. However, the LV function was severely reduced, and I think most of you had probably got that. You could code global hypokinesis. I think in this situation there were no thinned or scarred walls, and it didn't appear to be any one wall that was particularly hyperdynamic compensating, so it appears to be more of a global process. And then you'd skip coding any wall motion abnormalities, and there was a pleural effusion. Again, I think these are in smaller font because these were the things that the team of us that looked at this said, well, if they get the severe aortic stenosis, if they get that there's LV dysfunction and concentric hypertrophy, that's probably where the money is, the points are going to be mostly garnered. But I think it will be important to know whether it's for the main ABIM board with the multiple choice questions, or whether it would be for the coding session, how to calculate an aortic valve area. This is probably what we consider now bread and butter in the echo lab, and most of our patients don't go to the cath lab to decide whether they have severe aortic stenosis or not. So an aortic valve area is calculated by the left ventricular outflow tract diameter squared times that constant 0.785 times the TVI of the LVOT, then divided by the TVI by continuous wave Doppler of the aortic valve. So if we took the numbers that we had given you, there was 2.2 for the LVOT diameter. The constant, of course, is 0.785, which, and then we had the pulse wave Doppler through the LVOT of 20, and the CW Doppler through the aortic valve of 118. That gives you a valve area of 0.6, which of course, with that mean gradient, even without the valve area calculated, you probably already were thinking this is severe aortic stenosis. And we know now that the criteria for severe aortic stenosis is a centimeter squared or less, the peak velocity of greater than 4 meters per second, which this patient had, and also a mean gradient of 40 millimeters of mercury or better. And then this is more of a practical point, but you want to make sure whenever we're looking at patients with aortic stenosis that we align with the flow of blood. And what we found out, actually, Dr. Ali did some work in our lab as a fellow, and he found that the right parasternal window, and in fact it's even higher, it's getting higher all the time, because as we shrink, our hearts become more horizontal, and it points our aorta more to our right shoulder than it does from the apex. So we tend to use that right parasternal window very, very commonly, as well as the apex. But I think it's very important for our sonographers to be trained in the lab to also look from the subcostal windows and from the supraclavicular and the suprasternal notch windows, depending on how the heart lines up. So these are important practical more than testable things that you'll want to know as you go through your cases in your boards in taking care of patients in real life. So moving on to case 8, we have a 43-year-old female with edema and fatigue. And so we can see here that we're doing a little bit of an off-axis view. And I'll just tell you from the parasternal window, but I'm not sure our board examiners would be that generous, but we'll take whatever we can get, right? And then I'm going to show you a couple more images here. So now we have the non-classic Mayo format. The left ventricle is on the right side of your screen, and the right ventricle is on the left side. Here's the mitral valve. Here's the tricuspid valve. But regardless of which format I would have chose to show you this, you would have known that because the tricuspid valve is more apically oriented than the mitral valve. Just to reiterate a point that we made earlier. All right, with those 4 images then, please key in what you think the major points are, and I'll give you back a couple of the key images here while you're coding. All right. So what we coded in this case was a 43-year-old woman with edema. We went right away, we recognized something's wrong with the tricuspid valve. It fails to coapt. It was just sitting across the ventricle, the right ventricle from each other, and it wasn't coapting at all. This is classic for carcinoid, and of course, with that completely malcoaptation, I think even though we weren't giving any quantification, we weren't giving any PISAs, but when you really have failure to coapt and we really have one single chamber between the right ventricle and the right atrium, that's overwhelming evidence that you have severe tricuspid regurgitation in that setting. The right ventricle was enlarged, and there was global hypokinesis of the right ventricle under the RV tab, and then under your atrial tab, you would choose right atrial enlargement. So here you can see in diastole and systole that the tricuspid valve essentially doesn't move in these still frames. And then with the onset of color flow, it's really kind of a low velocity, but fills the entire atrium. And really, with the complete malcoaptation of those leaflets, we would have to imply that there was severe tricuspid regurgitation in this patient with carcinoid valvular heart disease. The typical carcinoid valves get restricted, they get shortened, they become very stiff, and as that happens, of course, the mitral annulus dilates and we get significant tricuspid regurgitation. So carcinoid heart disease is caused by carcinoid tumors. These are serotonin-producing tumors that usually affect the right heart over the left heart. They produce vasoactive substances that cause plaques to form on the valves, and then these vasoactive substances are taken through the lungs where they are typically are degraded, so they don't affect the left-sided heart valves unless you have a shunt, so a patent foramen ovale or an ASD, or unless you have overwhelming carcinoid syndrome and you actually have carcinoid tumors metastases to the lungs, then you can have left-sided valve involvement. Case number 9, a 28-year-old male with atrial fibrillation and edema. And this is actually in a congenital format, so I'm not 100% sure that I'd like feedback if you see these, but the congenital colleagues will put them in this direction, and they are testing congenital diagnoses, so you may see them in this format. But remember, if you're trying to get yourself oriented, you first find where the tricuspid valve is in relationship to the mitral valve. Where's the lower valve, the more apically displaced valve? That's going to be your tricuspid valve, and that's going to be your right ventricle. And then in this case, you can see that it's very disorienting because there's a lot of unusual anatomy, and then the color flow shows a fair amount of color across that valve. All right, so those are the only two images, so we have to key in what we think is going on with that unusual looking echo. Oh no. So this is the 28-year-old male with atrial fibrillation and edema, and this is a congenital format echo, and so we have a congenital diagnosis of Ebstein's anomaly. Under the valve tab, you would probably want to say that this is another tricuspid valve that doesn't coapt normally. Its function is bad. It doesn't coapt at all, so we can assume then, especially with that low velocity, full color in the right atrium, that there's overwhelming evidence that we have severe regurgitation. The right ventricular function, again, I think it's more of a minor issue. You really just want to get that major congenital diagnosis and severe tricuspid regurgitation, but the right ventricle was enlarged. In fact, the left ventricle was really squished, and that was somewhat disorienting in terms of looking at those pictures because we're trying to orient ourselves. And there was global hypokinesis of the right ventricle, and of course the right atrium was enlarged because it actually goes all the way down into the right ventricle. So those of us who don't see a lot of features of Ebstein's anomaly, it is the septal displacement of the tricuspid valve into the right ventricle. It leads to tethering of the septal leaflet of the tricuspid valve and elongation of the anterior leaflet of the tricuspid valve. That leads to severe tricuspid regurgitation because that septal anterior leaflet can't move over and coapt appropriately with the other two leaflets of the tricuspid valve. Because of that, the tricuspid valve, we have an atrialized right ventricle because it's essentially a whole chamber. There's very minimal functional right ventricle as the atrium gets so big and the tricuspid valve is so displaced and so tethered that you can hardly recognize the right ventricle as such. And that leads to ventricular dysfunction. There is some dysplasia of the right ventricle and maybe even the left ventricle in these situations. And it does have some associated defects, such as an atrial septal defect or patent foramen ovale. Either one have been associated with Ebstein's anomaly, pulmonary valve stenosis, ventricular septal defects, mitral valve prolapse, bicuspid aortic valve, and left ventricular outflow tract obstruction all have been associated with Ebstein's anomaly. And here's a pathologic specimen from our good friend in our cardiac pathology lab, and you can see the small in relationship to enlarged right side of the heart. So here's the left ventricle. Here's the what should be the right atrium, but really because these leaflets are so tethered down, you really have the right atrium filling most of the right ventricle and really just a small what's left of the right ventricle at the apex then. And that they get these boot-shaped hearts with a very narrow pedicle. And this is a cartoon example of what we see with a septal displacement. You can make the diagnosis of Ebstein's anomaly by noting that the displacement, and remember the tricuspid valve is always displaced towards the apex compared to the mitral valve. So we say, well, how far displaced is abnormal? Well, if it's more than 8 millimeters per meter squared, then that is the definition of displacement, and it can be, and there's a spectrum of Ebstein's anomaly. Of course, this particular example that we showed you just now was very, very severe, but there is a spectrum of Ebstein's anomaly. And there's a small functional right ventricular, right ventricle that's left, the enlarged atrialized right ventricle, a dilated tricuspid annulus, dilated and enlarged right atrium, and severe tricuspid regurgitation. Here you can see this flail-like lateral anterior leaflet, and you can see the tacked down septal leaflet and very little of the right ventricle in our congenital format. So again, not to scare you, but there are going to be some congenital diagnoses. I'll try to show you several of them here today, but if you're studying, you want to make sure that you go back and make sure that you're familiar at least with the very classic forms of congenital heart diseases that are listed on that answering sheet. So our next case is a 40-year-old male with dyspnea, and you're going to get 4 shots of his heart. And with that, I think we'll move on. So you can go ahead and key in your answers. We'll bring those images back, the key images, so you can take a peek. All right, so we'll see what we coded for this. This is a pretty straightforward case, but I think there's 2 tumors of the heart that I think would be well in your realm of things that would be very testable, and this is one of them. It's the atrial myxoma, and that's what we coded for this under atria and in a large left atrium. You could talk a little bit about, there was some mitral regurgitation, again, not overwhelmingly important in this case. Mitral stenosis, because that thing was going right through the mitral annulus and clogging it up during diastole. And you could possibly say something about LV function. It's always hard for an echocardiographer to not say something about LV function, but I don't think it's very important in this particular case. So myxoma is all, I think if they give you a myxoma, it's probably going to be more the classic type. On echo boards, they'll probably test your range of knowledge about myxomas, but they're usually an atrial structure, left atrium, much more common than right atrium. They tend to be attached to the atrial septum, as you can see in this example here. They do have this heterogeneous appearance. This one's more homogeneous, but depending on what other components are in these interesting tumors, they can be multi-lobed or polypoid, or they can be smooth like this particular myxoma was here. They do have some dermal and glandal elements within them, and they can have interesting syndromic presentations that I don't have time to go into now, but I would definitely be familiar with the myxoma, and I'm sure that if they, well, I shouldn't say I'm sure, but I'm pretty sure that they would give you a classic myxoma because these are pretty rare. All right, case 11, moving on, is a 50-year-old male with palpitations who is getting an echocardiogram because of those palpitations, and you can see several different views. This one might need some explanation as a short axis view of the apex on the right lower hand of your screen. Let's go ahead and key that in now. I'll give you back the important 4 shots that we had there. All right. So we're going to go ahead and reveal the answers at this point. The 50-year-old man with palpitations has, under the LV size tab and function and structure, we're going to talk about the left ventricle being enlarged. We're going to code there are regional wall motion abnormalities. And so that's the big box. There's abnormal wall motion. And then under that, you're going to check aneurysm at the apex. So you'll go to the apical wall motion column and you'll check aneurysm and severely reduced overall systolic function. And I think that's about all we can say on that one. We weren't given any color flow or any other views. So you can see that there's 2 possibilities to code under aneurysm. One would be an apical aneurysm, as this is an example of this patient with a very wide-based neck. So you have this very large dyskinetic almost when the base of the ventricle contracts. You see this apex just kind of almost going in the opposite direction compared to what's a pseudoaneurysm. Really, a pseudoaneurysm is just a rupture that's contained by the pericardium. So you have a free wall or apical rupture in this case, and you can see flow going through a narrow neck here. And there is a ratio that's been published, but I think that, again, for most of us can just gestalt it. You see a wide neck, that's an aneurysm. If you see a narrow neck, such similar to this, with high flows into the cavity, it's going to be a pseudoaneurysm contained by that pericardium. And then for your interest, we put a couple operative Sunil, these came from Sunil Mankad's collection. You can see the aneurysm. They cut through its muscle all the way around, well, scarred muscle tissue, and he's pulling out a large thrombus in this particular case. Our case did not. The one that we just coded did not have thrombus, but you would be concerned about that. And that's compared to LV pseudoaneurysm. And on this echo, you can see the rent, the structure here where there's actually a rupture through the free wall and a contained area where flow is going into the pericardium, but because of inflammation, it's been scarred down, and the surgeon shows us how that was reconstructed on the top up over here. You can see, shows us there's a hole out into the pericardium that created that pseudoaneurysm, which is really just a rupture, and it's contained by the pericardium. And for your reference, we've got the true aneurysm and pseudoaneurysm. Again, pseudoaneurysms have pericardium around the outside. True aneurysms have scarred myocardium around the outside, broad versus narrow. I think that's about what you need to know for that. Okay, case 12 is a 35-year-old asymptomatic male. This is just one image, so you might get something like this on boards where they just show you one thing and they just want to make sure you really are familiar with this. It's a very zoomed up view, so it might be a little bit disorienting, but you can see short axis of a very familiar valve there. And we'll have you key that in because there's really not too much more to say about this. I'll show you the picture back again. All right, I don't think it probably took 25 seconds to fill that one in because this is a asymptomatic gentleman with a bicuspid aortic valve, and that's a pathology that we definitely want to be familiar with because it's associated, of course, with an aortopathy, and we want to be sure we don't miss it, even in asymptomatic people, whether it's by physical exam and we're hearing that ejection click, or whether it's by echocardiography that we're doing because someone might have heard a murmur. Prevalence is about almost 2% in the general population with a male predominance. And here you can see another view, different orientation, the raphe between the non-coronary cusp and the right and the left coronary artery right here. And you compare that then to the trileaflet valve. It's really important to pay attention to the opening of the bicuspid valve because it opens in a kind of a shape like an American football. If you only look at the closing of the valve, you might be fooled because sometimes the raphe will make it look like that nice peace sign or Mercedes-Benz sign. But look at how they open. Pay attention to the opening. This one opens more in a triangular shape. That's normal. This one opens more in a football shape. That's bicuspid. And that's how you make that determination. You can also possibly see the eccentric opening on M mode with a regular M mode that's in a normal patient. The aortic valve gets completely flattened against the sinuses as it opens up, and you see very little of the valve, and it closes right in the center of the aorta. In the patient with bicuspid aortic valve, it opens eccentrically a little bit, but also doesn't completely open to the sinuses. And when it closes, it's eccentric. It's off axis of the center part of the ascending aorta. So that's another clue, and another place where M mode can help us out if we're a little bit not sure, if we're actually able to be sure that this is a bicuspid aortic valve. You can have your sonographer slip an M mode down that ascending aorta just at the leaflet tips and see if it closes eccentrically. So that may be one other classic M mode that you want to keep in mind. Case 13 now is a 45-year-old with a TIA. And now we're introducing contrast. So I think most people are using contrast in their labs nowadays, but this is a tool for endocardial border definition, and it really lights up the endocardium, that layer of endocardium. It's great for stress echo if you're having some difficult issues, but this was a resting echo in a patient that had had a transient ischemic attack. So we have a picture of the LV here, a short axis here, and then a zoom view of that short axis. Let's go ahead and key in your thoughts now, and I'll give you back the images so you can see them while you're keying in. All right. Well, we'll go ahead and get the answers now, and we can see that this 45-year-old gentleman was very unfortunate at a very young age to have suffered apical infarction. His LV size and function tab, we would code abnormal wall motion. There was an LV mass or thrombus that we would code in, and that there was an apical aneurysm with the thrombus. So contrast is very helpful in these situations. If you see a shadow or something at the apex, to reach for that contrast and use it to help distinguish it. You could see that there was, in fact, I'll go back and show you that image in case you didn't catch it, that this, especially here and here, you can see that although the endocardial border definition is, maybe you might wonder about the thrombus there, but you can see when you put the contrast in, you get endocardial border definition, you actually get myocardial enhancement, and you can see this area where there's no contrast enhancement. That's not being perfused, and it's sticking into the ventricle, and it really proves that we have a thrombus at the apex. Case 14 is a 63-year-old with dyspnea and hypotension. And we see this long axis view from a peristernal long axis and a peristernal short axis view. I'll give these images back to you, but go ahead and key in your answers. All right, so let's see what we coded for this one. So 63-year-old with dyspnea and hypotension, I think you could see that we go under our pericardial tab, our pleural disease tab, and she had a large pericardial effusion that was causing tamponade. The LV size and function, you might code those as being LV was normal size and function, ejection fraction appeared to be normal to hyperdynamic. Go back and see here what we see in diastole. You can see that there's collapse of the right ventricle. Whether you look at it in the long axis view or whether you look at it in the short axis view, there's a lot of fluid around the entire circumference of the pericardium. Pericardial fluid, sometimes it can be hard to tell pericardial fluid from pleural fluid. Here's the aorta. The pleural fluid will traverse between the heart and the aorta. So when you see that in this long axis view and you identify your descending thoracic aorta and you see fluid between the left atrium and the aorta, you know you have a pericardial effusion. And then tamponade, just because this patient has collapse and we know she's hypotensive. Now they might give you the blood pressure, you could see, possibly use all the information, maybe she was tachycardic, but I think the classic swinging heart was helpful. Here's another 4-chamber view, an older echo image where you really have collapse of both right atrium and right ventricle with this significant pericardial effusion. So that's a 2-dimensional suggestion that there's tamponade, and in the right clinical scenario, we obviously know that we've got a hemodynamically compromised situation that they would not want us to miss. So our 15th case now, we're doing pretty well. I've only got 10 more to go. 60-year-old with renal failure and heart failure. And so you see this peristernal long axis view, peristernal short axis view. That goes along with this EKG. I'm not sure they're going to do that, but I'm so nice I gave it to you anyway. They might describe an EKG though. I have seen them do that. And then again, Mayo format with the right ventricle on the right side of your screen, left ventricle on the left side of your screen. And now we're going to get a bunch of Doppler data, and you can see the E wave is 1.1 meters per second, the A wave is 0.4 meters per second with an E to A ratio of 11. Deceleration time of 138, left atrial volume index was 40. The E prime, and this is a septal E prime, is 0.04 meters per second with an E to E prime ratio of 28. And tricuspid regurgitant velocity was not able to be obtained. Go ahead and key in what you think you should key in for this case. It's relatively complicated, but I'll give you back what I think were the key data. All right. So we coded for this case a number of things. So 60-year-old with renal failure and heart failure. So you always keep these echoes in clinical context. It's impossible to read an echo in isolation without some understanding of why the echo is being ordered. In this patient, the main thing here was, probably most of you got it, it's amyloid. And it's under the systemic diseases. And the LV size and function and structure, we would say diastolic dysfunction, grade 3. We would say wall thickness, concentric increase. Left ventricular size was normal. The ejection fraction was normal. Maybe, it only gives you normal to hyperdynamic, but I would say that ejection fraction was normal. The atria were both enlarged. There was a pericardial and pleural fluid. Now, the pericardial fluid, you could argue about how much there was, but there was a definite pleural fluid that I think you should probably have noted. Again, I think it goes along with amyloid. So I think as long as you get amyloid, you're going to get the major points. But it does actually contrast quite nicely with that last case that we have, because if you look at this parasternal window, you see this little bit of fluid. Now that's not a tremendous amount of pericardial fluid, but it does go along with amyloid. Here's the aorta. There's that little fluid between the aorta and the left atrium. And now you see this fluid that comes next to and maybe even a little bit behind the aorta, and that's around the lung. This is some collapsed lung. That's pleural fluid. So that, I think those two cases kind of back to back help us to distinguish what we see between a pleural and a pericardial fluid collection. And of course, we see end systolic volume decrease, and the ejection fraction, if you calculated it, would be normal. If you did strain, it wouldn't be normal. So saying systolic function is normal might be a problem for some of us in the echo lab, but I think at least the ejection fraction, as we think about it, would be normal here. Now, diastolic analysis has changed. They're trying to make it simpler, and the American Society of Echo have given us a new way to look at diastolic function. So if we run through with this particular patient, the E over A was 28. It was very high. The septal E velocity was very, very low. It was like 0.04 or meters per second, or 4 centimeters per second. We didn't have a TR velocity, but the left atrium was enlarged. And so we would say that we have over 50% of these 4 criteria positive, and that's diastolic dysfunction. But the board still wants us to try to categorize what type it is. And this is something that we have used in previous years, kind of a modification from the last American Society of Echo grading of diastolic dysfunction. And if you think about this particular patient, again, very low E prime septally. We didn't have the lateral E prime, but we also had a left atrial volume index that was enlarged. We had a huge E to A ratio. It was 11. And a very short deceleration time, I believe it was 138. And with the E to E prime of 28, we would put this patient in to the category before you even have to go through the A reversal to aortic or atrial wave across the mitral valve, and you could do a Valsalva E to A too. But anyway, I think with just those criteria, you could already place this patient in grade 3. So I like this little chart, at least in the echo lab. I think it helps us out a lot to actually be able to say how significant someone's diastolic dysfunction is. But I think the main point on this particular case was you didn't want to miss the diagnosis of amyloid heart disease. And amyloid heart disease is associated with mild valvular disease. It can be multivalvular regurgitation that's usually fairly mild. It can be worse, but oftentimes mild, with low to normal voltage on the ECG, and that would be classic, but about there are some patients that have normal or even elevated voltage. So for testing purposes, they're probably going to give you the classic amyloid because it's a fairly uncommon disease. But for your clinical practice, keep in mind that if you're thinking amyloid for other reasons and the ECG doesn't fit, don't worry about it, because there could be up to 10% of patients with amyloid that have normal or even elevated voltage. And diastolic dysfunction, we used to call amyloid a restrictive cardiomyopathy, but it can be any grade of diastolic dysfunction, 1 through 4. And pericardial or pleural effusions are often present. And we have to be really cautious about these patients because they can have intracardiac thrombi, especially in the atria, but all 4 cardiac chambers have been shown to have intracardiac thrombi. So never cardiovert a patient with amyloidosis. without checking for thrombi with TEE, even if even if they've been recently in sinus rhythm, because they have a high propensity, even when they are in sinus rhythm, because of the atrial amyloid and atrial standstill and that smoke that develops, to get significant clots in their hearts. And of course, there's the classic EKG, but I will leave you with a take-home point that a fair but not insignificant percentage of patients could have normal voltage and still have amyloid. Case 16 is a 41-year-old with chronic IV drug abuse and fever and malaise. Again, they're going to give you a little vignette to think about. And here we have typical Mayo format that it's a little bit tilted, so the tricuspid valve is a little bit harder to tell, but that is the right side. Here's the moderator band. That's another clue that you're dealing with the right ventricle. With color flow in your lower panel, here's CW through the tricuspid valve. I'm not sure that they would label that for you, but they'd have to give you some clue. They'd have to show you where they were doing it on a thumbnail. So I just labeled it. And here's hepatic vein pulse wave Doppler. I have to take a little look at that. And now we'll give you back the images while you're keying in your answers. All right, let's see what we quoted on this one. So here's the major shots again that we had. And what you can see is the tricuspid valve is really not coapting flail. It has something on it, and it's associated with quite a bit of color flow. The overwhelming evidence is that you have systolic reversals in the hepatic vein, and you have this dagger-shaped tricuspid continuous wave Doppler where it's not rounded like our normal tricuspid regurgitant velocity is, because the pressure in the in the right atrium and the right ventricle equilibrates so quickly it chops off the end of that tricuspid regurgitant signal. So in this case, because of those features, this is a 41-year-old with a chronic drug abuse with fever and malaise, so he's got endocarditis. So under the valve tap, the tricuspid valve fails to coapt. There's a vegetation, and it's flail because it's flopping all the way back into the right atrium. In the tricuspid valve function, there's overwhelming evidence that there's severe tricuspid regurgitation. I think a lot of us would have even said that by color flow, but sometimes with those central jets we can be confused. But when they don't have coaptation, when there's systolic reversals and we have that dagger-shaped tricuspid CW signal, we have really overwhelming evidence that there's severe tricuspid regurgitation without PISA or any other kind of quantification. And of course, the atrium was enlarged because of that. The case 17 now is a 60-year-old with a previous heart surgery who presents with fever and dyspnea. And you can see the apical four-chamber view, and now we have the tricuspid valve on the left side of your screen. Right side of your screen is the left ventricle, and we throw color flow on. Again, for your viewing pleasure, this is one of those really beautiful mosaics that we shudder to see. I want you to go ahead and just take those two images and key in what you think the answer would be appropriate for this particular patient. All right. So this is a very important diagnosis not to miss. This is a 60-year-old who had previous heart surgery, presents with fever and dyspnea. And this is a dehisced mitral prosthesis with pathologic regurgitation rather than functional regurgitation. And there's severe mitral regurgitation. And we can maybe go back and look at the overwhelming evidence, but there's probably prosthetic valve endocarditis because it's dehisced. And also they told you that she has fever. And then I think the LV size and function, you could argue whether or not that needs to be coded. Again, for me as an echocardiographer, if I see a nice 4-chamber view and it's really hyperdynamic like that, I probably would code it. What they don't want us to miss is this rocking valve. This is the kind of thing where you've got one hand coding your echo and the other hand on the phone calling the surgeon to do an emergency intervention, because this is a valve that's about to fly loose. It's practically unhinged and it's rocking. So when we say the valves are rocking, this is the classic rocking valve. And the overwhelming evidence is this mitral regurgitation coming through this very large perivalvular leak here with a wraparound mitral regurgitation. In this setting, this is an emergency, and this patient needs to go straight to the OR as quickly as possible. So that would be if you get these top two things, I think you have the major points that they would want us to appreciate on that case. So now we'll go on to case 18, an 80-year-old with a TIA. This was a TEE done for source of embolism. Probably the number one reason we get TEEs done in our echo lab here is by our neurology colleagues ordering them. And I'm only going to give you one view here. A transesophageal echo. So we'll have you go ahead and key in your answer for this particular case. Again, I don't think it'll take the whole 25 seconds, but we'll let you look at the picture again while you're keying those in. All right, I think most of you probably got this, and that is, it's a left atrial thrombus. I'll show you again here where you can see the TE probe right behind the left atrium. The left atrium is here, the left upper pulmonary vein. This reflection right here of tissue, often fondly referred to as a Q-tip sign, because it's the reflection of pericardium that lines the left upper pulmonary vein and the left atrial appendage, and there's a little potential space there. And in this case, there's a little bit of pleural fluid there. There's a little fat in that, and that gives you the appearance. And we used to get a lot of calls about this being a possible mass, but that's a normal finding. But this is not normal. This jiggly mass that's in the left atrial appendage, you can see a little bit of the coronary artery here, the left main splitting into the left anterior descending and the left circumflex that goes underneath the left atrial appendage with our tri-leaflet sclerotic aortic valve there. We coded atrial thrombus. You could discuss whether or not you want to code left atrial enlargement, anything about the aortic valve. I don't think I would say in this case, but for sure the main thing is left atrial thrombus on this particular patient. And that's a very, very important thing for echocardiographers to be able to identify. All right, our next case is a 53-year-old asymptomatic female, but there's a murmur. And so this echocardiogram was done, typical male format again with the LV, RV. You see some color flow here with a color flow box, and then there's a short axis view here of the left ventricle. And then we'll go ahead and key in your answers, but while I do that, I'll bring back the key images that we were looking at. Some nice color findings there for your viewing pleasure, as I say. So what did we key in for this particular 53-year-old asymptomatic female with a murmur? She has go to the congenital heart disease tab, and she has a muscular ventricular septal defect. So I don't know about how many of you feel uncomfortable with congenital diagnoses, but I thought it'd be important to go through a few of those because this patient does have a muscular ventricular septal defect. It's restrictive, so you could see the color flow going from left to right ventricle. And you might think about coding normal LV size and function. I don't think that would be an issue. Now, there's several different other options for ventricular septal defect on that coding sheet, so I thought I'd take a minute just to go review those. So here, now that particular patient's ventricular septal defect was way down in the muscular part. This particular shunt we see just under the aortic valve, and from this view, we know that it's probably up close to the membranous portion of the septum, but we're really not sure, is it membranous or is it supracrystal ventricular septal defect? So how do we tell that in the echo lab? Well, what we do is we take and we turn the probe to the short axis view of the aortic valve. And within the short axis view, we can see where that flow is. If it's on the pulmonary valve side, which is right in here, don't think the leaflets of the pulmonary valve show up as well as I might wish with that color there, but this is the vicinity of our pulmonary valve. That's where the shunt is, and that is a supracrystal or otherwise known as outlet ventricular septal defect. Over here is the tricuspid valve, and I'll show you just for comparison's sake, looking at a membranous ventricular septal defect, which is more on the tricuspid valve side of that short axis image. So if you're on the pulmonary valve side of the aortic valve, just under the pulmonary valve, that's supracrystal or outlet ventricular septal defect. And if you're on the tricuspid valve side, it's a membranous septal defect. And now you know how the mystery of the congenital specialist figures these out. All right, case 20 is a 30-year-old with cyanosis, so another congenital case for you. I don't think I'm giving too much away with that. And you can see several key views, parasternal long axis with color and two-dimensional, and a tip-up view with some continuous wave color flow and then continuous wave Doppler in what would be the vicinity of the pulmonary valve. Why don't you go ahead and take another look while you're keying in your answers on this one? So this is a 30-year-old with cyanosis who has, I already had told you to go to your congenital heart disease tab, tetralogy of Fallot. And probably, although it's part of the tetralogy, you'd want to code membranous ventricular septal defect. And then the valvular heart disease associated with tetralogy is pulmonary stenosis, which by the CW, the Doppler that you saw there, was severe. And then left ventricular size, function, structure, normal. You could code that if you wanted to. I don't think, again, it's the main issue. If you get tetralogy, I think you're really, that's what the money shot is. So what is tetralogy? Just to remind all of us that are in the adult world most of the time and not the congenital adult world. It's an overriding aorta, and then it also has pulmonic or right ventricular outflow tract obstruction. So there could be an RVOT obstruction or the pulmonic valve, which was really the stenotic part in this particular patient that I showed you. And the ventricular septal defect with the overriding aorta is pictured here. And then because you have the RVOT obstruction or pulmonary valve stenosis, you get hypertrophy of the right ventricle. So that's the tetralogy that we see. And here in the parasternal long axis view, you can see the aorta, a pretty obvious lack of echo here with the right ventricle, left ventricle, and the overriding aorta. LV size and function may be normal. Again, I think that's a minor issue in this case. You can see some color flow. Really not a whole lot of, it's almost a wide open ventricular septal defect, so you don't see a lot of turbulence of flow. Compare that to that membranous VSD where it was really turbulent and we could see it was restricted. This one is really wide open. And then we see this high velocity jet through the pulmonic valve. And if you could see the Doppler here is 55 millimeters of mercury for the mean gradient, so very high pulmonary valve stenosis there. Case 21 is a 20-year-old female with Down syndrome, and this is our congenital format again with the right atrium, right ventricle, left ventricle. And the reason I show you this is because this is the one instance where this tricuspid valve can lead us a little bit astray, but then we'll show you the real-time images of this particular patient, and I think in some ways this gives it away, the fact that these AV valves are really at the same level. The one exception, there's always exceptions to rules in medicine. You can see a zoomed up view from the top left to your top right of your screen, and then you can see color flow here in the crux of the heart. And here's a full screen view for you with color flow through the AV valves, again in the congenital format. Remember, the left ventricle is here, the right ventricle is here. And this is another one of those congenital diagnoses. I'll bring back the key pictures for you while you're keying in your answers in case you want to refer back up to the screen. And in this case, we have a 20-year-old female with Down syndrome who has, under your congenital heart disease tab, a primum ASD, a membranous VSD, an enlarged right ventricle. The primum ASD, the membranous VSD, those are your main codes. Now, what this is a complete AV canal, but they don't offer that to us as an option to check. But since they have this combination, I just thought I'd show it to you. Again, we saw significant mitral regurgitation through the AV valve and an enlarged left atrium and right atrium. And the clue was really at the crux of the heart where we saw the both AV valves coming off at the same level. That's the one exception to that rule that I kept pounding on the whole hour or so that we've been here together, that we can't rely on that. But it is a very classic view, and once you see it, I don't think you'll ever miss it. And that's why I wanted to share it with you, because I thought if they're going to put something like this on the test, we should be able to not be too worried about it and understand the combination of an underdeveloped leaflets, of septal leaflets, which come off the septum together at the same level. You really have a huge VSD with really not very much turbulent flow because it's really acting like a single ventricle. In our case, we also had an atrial septal defect, and it was pretty clear that that was there. So here's that view again. I think will really help you to see the primum atrial septal defect above the septum, the ventricular septal defect below the closing plane of the AV valves. And note that the AV valves are coming off at the same level. And there's your mitral regurgitation, not too much tricuspid regurgitation. Okay, case 22, we're winding down. So here's a 72-year-old gentleman with dyspnea. This is in the echo lab. And we gave contrast because these are not really your most beautiful pictures, and we weren't able to see the endocardial border definition well, but we weren't really sure how this apex was moving, so then contrast was administered. And I think you'll agree with me that the left screen, very almost willing to call this a very sluggish heart, but when we see the contrast, we see that it's a very small ventricular cavity, and the contrast really defines for us the outline of the endocardial border. And with that, I will stop narrating, because I know you're not going to have me with you on the boards. As much as I would like to be there for you, I'll go ahead and key in your answers. I'll give you back the key views. All right, so we have the answers here. 72-year-old man with dyspnea who has a cardiomyopathy. It's apical hypertrophic cardiomyopathy. This is normal LV size and function. I think you could see that small hyperdynamic left ventricular cavity with normal function. And you might code the atria was enlarged. I think, again, it may get a slight amount of credit for that, or maybe none at all. Apical hypertrophic cardiomyopathy is a pretty uncommon but very testable because it's difficult to know it unless you actually have ever seen it before. Here's a nice, that last case that I showed you, we really needed the contrast. This one we might not have needed the contrast, but we gave it anyway because in apicals we want to make sure there's no pouch out at the apex, which can increase the risk of embolization. And this one does not. This one just has a slit out at the apex. And compare that then to something that they also ask you about on boards, and that's eosinophilic heart disease. And that was one of our systemic diseases that they wanted us to be aware of. And if you give contrast here, the apex in two-dimensional may look very similar to an apical hypertroph. But when you give the contrast, what your apex is filled in with is thrombus. So they're very distinct, and really contrast makes that distinction for us between apical hypertrophic cardiomyopathy and hypereosinophilic or eosinophilic heart disease. Case 23, a 28-year-old female, 2 hours after a C-section delivery, you're called to do an emergency echocardiogram, and this patient has dyspnea, and this is the bedside echocardiogram that you're obtaining several hours after this patient delivered her baby. Okay, we'll code in our images, our answers, and I'll show you back the images again so you can see the key images. All right, time's up. So I think many of you probably figured this one out just by the clinical scenario alone, but you have to see the findings on the echo consistent with pulmonary embolism under your pulmonary disease tab. In the right ventricular, there was evidence of right ventricular pressure overload with that flattened interventricular septum that's classic for that. There was global hypokinesis of the right ventricle, and the RV appeared to be enlarged. This was sudden onset of pulmonary embolism leading to significant and abrupt pressure overload of the right ventricle. And the LV was normal in size and function. So that's what we coded. 2 more cases, and we're really on the home stretch here. So case 24, just one image, a 32-year-old hypertensive patient, and this is abdominal aortic Doppler from the subcostal window. This is one of those you know it or you don't know it, so we'll just go ahead and have you key in your answers. All right, let's take a peek and see what this was. So this is a patient with coarctation of the aorta. So under the diseases of the aorta tab, it's coarctation. And again, a very important diagnosis not to miss in our patients because it has significant implications for their longevity to pick these up. And the reason I said you either know it or you don't know it, we routinely will interrogate the abdominal aorta in all of our patients in the echo lab to see their Doppler profile as well as the size, screening for abdominal aortic aneurysms. But in this case, we saw not the normal pattern where you have a rapid upstroke and a rapid decline. You have a little bit of an early diastolic reversal, but then diastolic forward flow. So that's a typical systolic forward flow, diastolic forward flow that happens during in normal patients because the muscular energy is sequestered as the aorta retracts that muscular artery, it causes the perfusion during diastole. But in a patient with coarctation, with that narrowing, you have a very slow upstroke and a very slow decline So this is very classic for coarctation, a very spread out signal, and I think once you've seen it, you'll never miss it. Coarctation is really important because you can get a lot of different diagnostic images. Chest X-ray there, has a signature figure of 3 sign, which is really the aortic knob. You can sometimes see rib notching due to the increased flow in the intercostal arteries. And then the echo Doppler that I just showed you. Of course, CT MRI can help to confirm, or an angiogram, your suspicions by echo. And also, I always like to make the point with the fellows that there's a physical exam finding in hypertension where you have a brachial femoral delay. So if you feel the pulse in either the radial or the brachial artery, that'll be delayed from your femoral artery. And so in all of our hypertensive patients, we should be feeling that brachial femoral delay. This just shows the rib notching that we can see on chest X-ray. It gets eaten away on the inferior aspect of our ribs due to the increased flow and collateralization from the descending thoracic aorta. Here's the reason for the figure of 3 sign. You get dilation of the left subclavian artery, pre-stenotic dilatation and post-stenotic dilatation, and here's that figure of 3 sign on the chest X-ray. All right, our last case. So, case 25 is a 44-year-old male with slurred speech. This was his brain MRI. I don't think they'll be showing you any brain MRIs, but I think you can see that there was significant stroke on his brain MRI. And so, of course, being that source of embolization is the #1 referral diagnosis in our echo lab for patients, he came for to rule out stroke. So we need to make sure that there's nothing in the left atrial appendage here. And we're interrogating a zoomed up view of the intraatrial septum right here, just to orient you to these views with color flow on. And then we have a zoomed up view of the aorta and the aortic valve. And then again with color flow on the right side of your screen. All right, so we'll key in those answers because I know everyone's ready to get out and enjoy some of the nice sunshine. And I'll show you the key images again here. So this is an aortic valve fibroelastoma or papillary fibroelastoma. And we would also note that there was a patent foramen ovale on this. So whenever we see patients in the echo lab with source of embolization, we have to certainly rule out any sort of dissection that could cause a stroke. Left atrial appendage thrombus, one of the most common causes of stroke in our patient population. You need to look for a paradoxical emboli that could be caused by a patent foramen ovale or an atrial septal defect. But another, not that uncommon, but not that common, cause is something called a papillary fibroelastoma or fibroelastoma. And that is a small echo density, which is on the, usually on the valves. Most of them are on valves. And you can see in this two-dimensional zoomed up view, this very mobile echo density on the ventricular aspect of the aortic valve. And by three-dimensional interrogation, we can see that it actually is on the non-coronary cusp of the aortic valve, and that there's a lot of shimmering around the edge. The reason we get this shimmering around the edge is because these things are just full of these little frondy limbs, if you will, of the tumor. They're very complex tumors, and they get platelet emboli in between. The tumor itself can embolize, parts of the tumor can embolize, but they can also get clots between the fronds of the tumor itself. And then this is this patient after he had a shave excision of that papillary fibroelastoma, and he's doing well.